Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and also the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. This series is brought to you in part with a grant from the Iowa Cancer Consortium. Normally, I have a guest tonight, but tonight you get me by myself. So I'm going to talk to you all about cancer screening. When we talk about how to control cancer, how to reduce the burden of cancer, one of the biggest advances in reducing the burden of cancer in the last century has been the strides we've made in screening for cancer. Why is screening for cancer important? It's important because if we can find cancer at an early stage, before it is symptomatic, before it is causing any symptoms, then it's more likely to be curable. And there are 5 different cancers that we have verified screening mechanisms that will help detect a cancer before it's symptomatic and thereby improve the chances of curing. So again, a cancer screening test is a test done on an individual who does not have cancer and does not have symptoms of cancer. So that's what we're going to talk about. And so let's just get right into it. Let me bring up my slides here. And so we have several different organizations that have recommendations and guidelines for cancer screening. The one that many of us rely on is the American Cancer Society. So I want to start off talking about the American Cancer Society guidelines, and we can also open it up for questions anywhere along the time of this talk. So again, why do we do cancer screening? It's to find cancers at an early stage. Might make a comment about what we've gone through in the last couple years. So when we were faced with the COVID epidemic, as we were trying to determine in the health systems how many resources we were going to need to take care of COVID patients and to try to reduce the traffic of healthy individuals through the cancer center, we actually made a decision for a short period of time. Unfortunately, it lasted only for a few months, where we said, time out, let's hold off on doing cancer screenings of healthy individuals that are not symptomatic until we get a feel for how many resources that we're going to need to devote to the COVID epidemic. That, in retrospect, was probably not the best thing to do. It was done with good intentions, but when we told people not to come in for cancer screening, it took a while to get individuals to get their thinking reversed and get them back in to do their routine screening. Fortunately, at our cancer center, we only stopped screening for a few months and quickly rebounded. But across the United States, it's anticipated that the delay in cancer screening that took place because of the COVID epidemic may result in an increased death rate, increase of perhaps even 10,000 deaths over 10 years due to the lack of screening. So we learned a bit in that experience, and I think the next time we experience an epidemic, we may approach the slowdown of cancer screening differently. So cancer screening is based on the type of cancer and the age at which patients are at risk. So let's talk about the different ages. If we look at breaking down the ages of the patients from 25 to 39, 40 to 49, and over 50, we'll see that it changes based on the age. So let's look first at ages 25 to 39. Really, the only screening test that is shown to be of value in that young of a population is cervical cancer screening. And the best screening is a pap smear, and that begins for women screening at the age of 25. The next group would be the ages 40 to 49. And in this group, we do screening for 4 different types of cancers. Breast cancer screening is done for women beginning at age 45 with the option to begin at age 40. We're going to talk about different guidelines. The American Cancer Society guidelines still lists 40 as the screening age. There are other guidelines that would suggest that we could wait as late as age 45. Cervical cancer screening continues for women age 40 to 49. And colorectal cancer screening, we recommend that begin for everyone at age 45. This is a relatively new recommendation to begin colorectal cancer screening that young. It used to be age 50, but recent information has shown that the age at which individuals in the United States are being diagnosed with rectal cancer has decreased over the past decade. And as a result, guidelines have changed from starting screening at age 45 to starting screening at ages, from starting screening at age 50 to starting screening at age 45. And then the last is prostate cancer screening. We're going to talk more in depth about prostate cancer screening. We know that African Americans are at higher risk for developing prostate cancer than Caucasians. It's still not totally clear that screening for prostate cancer saves lives. So the recommendation is to have a discussion about starting to screen for prostate cancer. And for the African American population, it would be at age 45. Then once we get to age 50 and beyond, these are the 5 different cancers that we have screening tests for. Again, the breast cancer, cervical cancer, colorectal cancer, lung cancer, and prostate cancer. Lung cancer screening begins at age 50. Lung cancer screening, though, is only for individuals who are at high risk for lung cancer, and that are individuals that have a history of smoking. And we'll talk more about that when we get into the guidelines. Again, we're right now talking about the American Cancer Society guidelines, and let's talk about breast cancer. So for breast cancer, screening can begin at age 40, and this is the guidelines for screening women at average risk for breast cancer. A woman who has a strong family history or a genetic mutation doesn't fall into the category of normal risk. They fall into a high risk category, and screening for high risk individuals is different. Right now, I'm talking about screening for average risk individuals. Women's age 40 to 44 should have the choice to start their annual breast cancer screening with mammograms if they wish to do so at age 40. We'll see that the United States Preventive Task Force recommends starting at age 45. So there's some discrepancy, but the American Cancer Society still believes that women should have the right to begin screening at age 40. No doubt that by the age of 45, every woman should be screened. And the American Cancer Society recommends mammograms once a year. From age 55 and older, it's okay to switch to every 2 years. And the reason for that is by the time you've already had annual screening for quite a few years, breast cancers are typically slow growing. And the science shows that screening every 2 years is as effective in finding a breast cancer as screening once a year. The reason that many physicians feel that the annual screening is better is it gets women in the habit of doing it every year, and so they don't forget about it. The difficulty with every other year is you don't do it a year, and then the next year it's like, did I do my mammogram last year or not? Oh, well, maybe I did. I'll wait for the next year. Whereas that annual tickler of getting them back in. So the American Cancer Society believes that even though the science justifies every other year, that the way human behavior works, doing it once a year may end up being a better strategy to keep women coming back every year so that they don't miss. When do you stop doing mammograms? It's a very difficult question to answer scientifically. We don't actually set an age at which we say at this age, we stop screening women for breast cancer. The right answer is when a woman's health or her life expectancy, based on her age or her other health factors, make it such that you wouldn't treat an early stage breast cancer, then there's no reason to screen. We all know that there are some very, very healthy 80-year-olds, and we also know that there are some 65-year-olds that aren't very healthy. And the decision to stop screening is not based on just the absolute age, but it's based on one's life expectancy, one's other illnesses. And again, it comes down to the question, if I were to find a abnormality on a mammogram that might be an early breast cancer, would the patient's health and life expectancy be such that treatment would make sense? So those are the screening recommendation for breast cancer. Let's talk a little bit now about colorectal cancer and the American Cancer Society guidelines. I mentioned that this is one where there's been a change from starting at age 50 to now starting at age 45. And this, again, is evidence-based. There's been research and data showing that the age at which colorectal cancer is being diagnosed in the United States has gone down. And we believe now that everyone should be starting screening at age 45. There are different ways of doing colorectal screening. One way of doing it is to test the stool for blood and or DNA of cancer cells that we can actually test in the stool. And only if that test is positive, then to go to the colonoscopy. Another acceptable test is to go directly to a colonoscopy, and that is inserting a tube up into the rectum and looking through the colon directly. One of the advantages of doing colonoscopy as the screening is that when you're doing a colonoscopy, the physician doing the colonoscopy also has the opportunity to remove polyps, benign polyps, but polyps that over time might develop into cancer. So the advantage of using colonoscopy as a screening technique is it actually can help prevent cancers, because in the act of doing the colonoscopy, polyps may be removed that over time would have developed into a colon cancer. For people ages 76 to 85, here again, when do you stop doing colon cancer screening? The right answer is individually based. Does the patient's age, life expectancy, and other illnesses make it such that you wouldn't treat an early stage cancer? For someone who is healthy and fit, whose life expectancy is 5 to 10 years, then we believe colon cancer screening should continue regardless of the age. The next group that we're going to talk about is cervix cancer. And as we mentioned, cervix cancer screening begins at age 25, and that between 25 and 65, we should also get a primary HPV test done every 5 years. HPV, the human papilloma virus, causes 100% of cervix cancers. So screening for HPV is very important. We're going to talk at the end, after we talk about screening, we're going to talk about cancer prevention. And one of the ways of preventing cancer is by getting HPV vaccination. An HPV vaccination is a vaccination that happens in ages 11 to 13, and getting an HPV vaccination can actually prevent 6 different types of cancer. So we're talking now about screening, but better than screening is preventing. So cervix cancer, 100% of cervix cancer is caused by HPV. We still need to do screening because there's a lot of women who grew up before the HPV vaccine was in place, but we want to never talk about screening without also reminding individuals to get HPV vaccination to actually prevent cervix cancer. Next, Lung cancer. The lung cancer screening program is the newest of the 5 different types of cancer that we screen for. And this was based on a study that was done about a decade ago. And this is screening individuals who are at high risk based on their smoking history. So, in order to be placed in the high risk category, you have to have what we call a 20-pack year smoking history. So, a 20-pack year smoking history could be an individual who smoked a pack a day for 20 years. Or a half a pack a day for 40 years. So that's the math that gets you to a 20-pack year smoking history. And it has to be someone who has not who has smoked within the last 15 years. So even if you smoked a pack a day, but you quit 20 years ago, you would fall back into the normal risk and you wouldn't be eligible for lung cancer screening. So again, it's either a current smoker or someone who has quit less than 15 years ago, and someone who has enough smoking history that the number of packs per day times the number of years they smoke leads to 20 pack years. So what is screening for lung cancer? Screening for lung cancer is actually doing a CAT scan. And it is a low dose CAT scan that is done without IV contrast. So we worry about exposing too many people to too many x-rays because, believe it or not, x-rays can also lead to cancer. So a risk for developing cancer can be getting too many x-rays. So we're always trying to balance the risk associated with a screening test with the rewards. For lung cancer, the best way to screen for lung cancer is to get what we call a low dose CAT scan of the lungs that looks for small tumors that you would find before they ever became symptomatic. And the study that was done over 10 years ago showed that screening individuals at high risk for lung cancer actually led to the reduction in cancer death from lung cancer. So that has changed the way that we approach lung cancer screening. And as a result, we are finding small lung cancers before they would ever be symptomatic and finding them at a stage in which they can be cured. If you don't find lung cancer until a patient is symptomatic, coughing up blood, having chest pain, or the cancer has already spread, unfortunately, you're finding it at a stage where you're not likely going to be able to cure it. But finding a lung cancer at a very early stage before it's symptomatic leads to treatment that results in a high proportion of those early lung cancers being cured. So that has been something that has dramatically changed the way we approach lung cancer. And that's just happened in the last 10 to 15 years. Let's go next to talking about screening for prostate cancer. And this is very controversial. The whole focus of prostate cancer screening has changed dramatically during my career as a cancer doctor. So I have been a cancer doctor for over 35 years. When I was first a cancer doctor, the guidelines were that every man from 50 on gets a PSA blood test to screen for prostate cancer. PSA is prostate specific antigen. It's a fairly simple blood test to get. And for decades, every man, when they went in for their annual physical, would get a PSA. Why have recommendations changed? Well, we found that in the United States, where we made a big push for doing PSA screening, and if the PSA blood test was elevated, then we put the gentleman through a biopsy to see is there prostate cancer in the prostate gland. And if there was, then we went through and recommended treatment, either removal of the prostate or radiation. What we found over time, over decades, that in the United States where we did all of the screening, we found a whole lot more prostate cancer, but the actual number of men in the United States that were dying of prostate cancer didn't change. So we were diagnosing a lot of prostate cancer, but we weren't actually reducing the death rate. And that set of facts led to the conclusion that what we were doing was finding a lot of very early stage prostate cancer that was not likely to ever result in a gentleman's death, and putting them through treatment that had a lot of side effects, but we weren't actually saving lives. And that resulted in a change in our recommendation regarding prostate cancer screening. So let's go back to the American Cancer Society's recommendation about prostate cancer screening. And so the American Cancer Society recommends that we have a conversation with men about the risks and benefits of screening, that we don't just systematically do a PSA on every gentleman from age 50 on to look for an elevated blood test. One other piece of information that can provide comfort to individuals is there was a study where we did autopsies of the men ages 90 and older who died of normal causes. And we found that 90% of men that age had some prostate cancer in their prostate gland, but it didn't result in any health consequences. So we know that having a little bit of prostate cancer in the prostate gland is very common, but dying of prostate cancer is very rare compared to the number of men that might have prostate cancer in their prostate gland. So again, the American Cancer Society recommends that rather than just routine screening, and again, these are for men of average risk, not men who have a strong family history of breast cancer of prostate cancer, not men who have a genetic mutation, but men of average risk, we should have a conversation. There's not a right or wrong, and I'm not telling you that I am correct, but I'm telling you that I'll be 70 next year. I'm a cancer doctor, and I don't personally go through routine screening of PSAs. Science will continue to evolve. Whether my strategy and the strategy of my doctor proves to be the best strategy, we'll learn over time. But I can tell you, I feel comfortable enough about not getting a PSA that's the strategy I'm taking for myself. Let's go back to the screening. And next, endometrial cancer. So the American Cancer Society recommends at the time of menopause, women should be told about the symptoms of endometrial cancer and that they should report any vaginal bleeding or spotting, but that we don't routinely do endometrial biopsies as part of a screening. So unless there is a family history or a genetic mutation, there is no science that proves that doing annual endometrial biopsies for women at normal risk is of benefit. Next, I want to talk about the other major guidelines, and this is the United States Preventive Services Task Force, often called USPSTF. Now that's a mouthful, and this is the official guidelines of the United States government for screening of cancer. What I've gone through up until now has been the American Cancer Society guidelines, and for the most part, they are in parallel. They certainly work together. The American Cancer Society tends to do a little bit more simplified guidelines that are easier to digest by the public and not so complicated that it requires an MD or PhD to understand the guidelines of the USPSTF. So I will stumble over that a little bit. Let's look at those guidelines. And before we do, their guidelines all are about risk and benefit, and they grade the science on which the screening shows that it reduces death rate by doing screening. And so there are grades. And so when we get to each different type of cancer and the screening, we will look at the grade. So if it's a grade A, it says this screening test absolutely is beneficial. There's high certainty that it is useful and that we should offer this service. With the B, it's that there's high certainty and the benefit is moderate, but that we should still offer the service. By the time you get to a C, it says, well, the evidence is there, but it's not as clear that we're providing benefit over harm, and that this service, this screening service, should be offered, but there needs to be considerable discussion with the patient on the risks and benefits. If the science behind the screening rates D, it's that the risks of screening outweigh the benefits, and you should not do the screening. And then there's the final category of I, where it's just inconclusive. The data is kind of uncertain, and so the USPSTF is going to say, we're not certain what to make of this. So let's go through those 5 different types of cancers that we do screening and look at how the United States Preventive Services Task Force does its scoring. So if we look at breast cancer, here the USPSTF, instead of, as the American Cancer Society said, okay to start at age 45, at age 40, the USPSTF recommends every other year screening from 50 to 74. And that is conclusive, that shows benefits. So it's a grade B, which is still conclusive. They believe that the evidence for women age 40 to 49 is not conclusive. And so their recommendations that for women young between the ages of 40 and 49, you should have a conversation with the patient about the risks and benefits of screening. So it's a difference between the American Cancer Society recommendations and the United States Preventive Services Task Force. Again, remember, the American Cancer Society believes that women age 40 to 49 should be allowed to screen. And I would say that in the United States, almost everyone follows the American Cancer Society guidelines rather than the Preventive Services Task Force. If we go to the next category, and that is some more about the screening. Now, these are all inconclusive. So there are other screening mechanisms besides mammography that we sometimes use for screening certain women at higher risk for breast cancer. Again, this talk is about screening women of average risk. So what about 3D mammography? Right now, that is inconclusive that 3D mammography is better than 2D mammography. And we are actually participating in a nationwide randomized screening trial comparing head-to-head 2D mammography versus 3D mammography. So why would you want to not do 3D mammography? Well, it exposes the breast to more radiation every year, and it's more expensive, and the data is inconclusive as to whether it's better. So there's no doubt that it is a very good test, but is it necessary, or could it be exposing more women to radiation that could lead to more cancers in the future? The second is other forms of breast imaging as screening. So ultrasound, MRIs, and other nuclear medicine testing. They all play a role in working up women who have certain breast abnormalities, but no studies have ever shown that those particular breast imaging should be used as routine screening for women at average risk. So again, they're very useful in working up a woman who may have an abnormality on a screening mammogram, but the data is inconclusive that you should use them as part of screening. And then the final insufficient data is, what about women 75 years and older? So if you look at all women of average risk 75 and older, the USPSTF would say the data is inconclusive to say that screening elderly women, even healthy elderly women, is of benefit. So I share these with you. I share the differences between the American Cancer Society and the USPT, PSTF, not to say that there's an argument, but to say that this is still evolving, and there are some different nuances of trying to have the screening guidelines be simple, straightforward, and easy to be understood by the patient, as opposed to relying specifically on evidence that has been proven beyond a shadow of a doubt. Let's go on to the next type of cancer that we do screening for, and that is colorectal cancer. And again, we're looking at the United States Preventive Services Task Force. So the column on the far right is the grade. So A, there is no doubt that colorectal cancer screening between the ages in 50 and 75 saves lives. Absolutely conclusive. And the task force also concludes that there's sufficient data between the ages of 40 and 49. So it's a B rating, not quite as good, but the rating B is a passing rating. And so the task force does recommend starting screening at age 45. Again, to repeat myself, that has been a change relatively recently to go from age 50 down to age 45. And that's based on our knowledge that we are now seeing colorectal cancer at younger ages in the United States. When we get to the age of 76 to 85, it's a grade C. So it might be useful, but the task force would recommend that this is where you talk about the risks and benefits of screening. So I've mentioned several times risks and benefits. So what's the benefit of screening? You may save lives. What's the risk? So people don't understand that there are risks. So for example, lung cancer screening. Well, what could be the risk of screening for lung cancer? Well, let's say you do a CAT scan and you see a nodule. Well, then you have to determine, is that malignant or is it benign? So you have to either undergo a bronchoscopy or poke a needle through the chest into the tumor. And believe it or not, there have been individuals who've actually died undergoing biopsies that turned out to be benign. So you have to factor that in, that you could cause significant medical harm and even death by doing biopsies. Rare, but it does happen. So we don't just screen people if we can't prove that it provides benefit. The other reason not to screen, even if the screening weren't to cause death, is it could be very expensive to screen the entire population. And if it doesn't provide benefit, you're just adding to the medical costs. It drives up medical costs, drives up insurance. And if it doesn't actually save lives, you haven't done anything beneficial. So again, that's why we talk about the risks and benefits of screening. So, talking about colorectal, these were the ages, these were the grades, and I do not expect you to be able to read this. I am showing you this slide to show you all of the complicated ways in which we can screen for colorectal cancer. I'm going to take that slide off because it is just overwhelming. I'm not going to teach you how you should do blood test, stool testing for blood, stool testing for DNA, the frequency at which you should do it, and the frequency which that should lead to colonoscopies. This is way too complicated for any patient to be able to remember all of that. When I talk to my patients, I say, it's kind of like your kids and getting vaccinations for the various illnesses. I don't know how. I wouldn't expect any parent to know exactly what age, which shots are supposed to be done, and things change. You should have a really good primary care doctor who has built into his electronic medical record which tests you've had done, when you've had them done, and when you're going to have the next test done. So know that colorectal cancer screening can include either testing the stool for blood or for DNA from cancer cells. And if that is positive, then doing the colonoscopy or going directly to a colonoscopy. Again, I'm repeating myself, but one of the advantages of doing the colonoscopy as the screening is that when the doctor does the colonoscopy, he will also remove benign polyps that could over time develop into a cancer. The disadvantage of going directly to colonoscopy is colonoscopy is a lot more difficult a test to do than testing a stool sample. It requires getting a clean out where you have a laxative the day before to get cleaned out. You have to go in, you have to have some anesthesia, you have to have the scope inserted, then you usually have to have somebody drive you home. It takes a day off of work. It's much more expensive. It requires some difficulty, but the benefit is it's a very good screening test and it may prevent a colorectal cancer. And then we're going to go next to, again, we're talking about the United States Preventive Services Task Force for the cervical cancer screening. This parallels quite well with the American Cancer Society. Again, I'm showing you this because this gives us the grades showing how effective the screening is, and an A grade for screening cervix cancer patients between the age, for screening women for cervix cancer, not cervix cancer patients, screening women of normal risk for cervix cancer between the ages of 21 and 65 definitely saves lives. When you look at screening women younger than 21, the science doesn't show any benefit. Screening women after a hysterectomy, doing pap smears after a hysterectomy does not save lives. And screening women older than 65 for cervix cancer does not save lives. So the recommendation is screening for women between the ages of 21 to 65. We're going to go to lung cancer screening, and this is also congruous with the American Cancer Society guidelines. So screening of adults between the ages of 50 to 80 who have a 20-pack year smoking history and are currently smokers or have been smoking within the last 15 years. And it's a grade B. It's absolutely conclusively saves lives when you screen individuals at high risk for lung cancer. And the final category that we're going to talk about is the prostate cancer, which is, as I mentioned before, quite muddled, that we used to believe all men should be screened. And the best grade you can get for screening for prostate cancer is a C, which is kind of like you should talk to patients about the risk and benefit of screening. And again, we're talking about normal population, normal risk population, not men at high risk. And the science is that you could make a case for screening or you could make a case for not screening. And it really requires a conversation with your doctor about the risks and benefits. Once it gets to screening men 70 and older, the task force recommends, the score is D, that by the time you get to be age 70, if you're going to find a prostate cancer in a man over age 70, it's probably going to be so low risk that the chances that they would ever die of that prostate cancer is so small that the risk of causing them harm by treating a prostate cancer over the age of 70 is greater than the benefit that they would derive. So again, that has been a change in the way we've approached prostate cancer here in the United States. So we've talked about the 5 different types of cancer that there are legitimate screening tests for, and under which circumstances those screenings should be done. And again, a screening test is done on someone who doesn't have cancer, who doesn't have symptoms of cancer, but a screening test is done on someone that may be at risk of developing a cancer, and it's done in order to detect a cancer at an early stage when the cure rate would be much better. I always like to add a little bit of a conversation about prevention of cancer. So it's good to screen, It does save lives. Oh, before we get to here's some of the don'ts. So the United States Task Force recommends that we don't do routine screening for ovarian cancer, pancreas cancer, thyroid cancer, and testicular cancer. Again, people at normal risk, and that's because we don't have good screening tests. There's still science being done, still saying, gosh, it would be good if we had a test that could detect early ovarian cancer, because that's one of those cancers that by the time a patient is symptomatic, is often advanced stage. But right now, we do not have a test that has been proven to be reliable. We also, the task force concludes that when it comes to screening for skin cancer, oral cancer, and bladder cancer, that the data is insufficient. Believe it or not, I mean, screening for skin cancer we do commonly. It kind of makes sense, but we in the United States probably spend a lot of time, effort, and money on getting small superficial skin cancers removed from our skin that wouldn't go on to be a significant cancer. So going in routinely every 6 months and seeing your dermatologist, it's not bad, but the data is really insufficient on whether it actually saves lives. It would be good if we had a better screening for melanoma, the one deadly cancer. But unfortunately, even though it makes logical sense to go see a dermatologist and have him remove every little blemish that might look out of line, we haven't been able to demonstrate that that actually saves lives. Let's go to now a talk about something that you're going to be hearing more and more about. So this is called the multi-cancer blood test screening. And believe it or not, there's already an FDA approved test. It is Gallery by Grail, and it is a blood test that can find up to 21 different cancers in your body. A blood test. The problem is you can detect some DNA from cancer circulating in your bloodstream, but you may not know where the cancer is. So this is going to change cancer screening, but right now it is not been proven to save lives, and it is not being done instead of the various cancer screenings that I've already gone over, and it is not paid for by insurance because it has not been proven to save lives. I have no doubt that within a few years, we're going to see this come into mainstream. Right now, it costs $1,000 out of pocket. It is not covered by insurance. And one of the problems is if you get the blood test and you get called up and say, your test was positive, we think you have cancer in your body. Then it begins the process of looking to see if you can find it. There are tests being done now to see whether doing the screening and then doing the follow-up testing and finding the cancer leads to finding these 21 different cancers at a stage that results in a higher cure rate than just the standard screening. But it's very exciting. The science is fascinating. It is going to change cancer screening within the next decade. I want you to know about it. It's not ready for prime time yet, but that's the multi-cancer screening blood test. And the one on the market right now is a Gallery by Grail. Let's now shift focus, as I keep saying we're going to do, to talk about cancer prevention. About 50% of cancers in the United States could be prevented. And if you can prevent a cancer, that is the best way to reduce the death rate of cancer in the United States. Second best way is to find it early. First, the best way is to prevent the cancer to begin with. So about 50% of cancers in the United States are caused by cancers that could be prevented. So how do you prevent cancer? Well, number one, you don't smoke. Smoking is still the number one cause of cancer in the United States. So don't start smoking. If you do smoke, stop smoking. that will prevent cancer. Second, obesity, inactivity, and too many calories causes nearly as many cancers as cigarette smoking. Let me repeat that. The combination of obesity, eating too many calories, and not exercising enough, that combination causes almost as many cancers in the United States as smoking. So if we could all not smoke, maintain a normal body weight, eat a good nutritious diet with a normal number of calories, and exercise daily, those two things alone would reduce cancers in the United States by probably 40%. What are some of the other things that we can do? Not drink more than 2 alcoholic beverages a day. Get your HPV vaccination. Protect your skin with sunscreen so that you don't get skin cancers, especially the melanoma that's directly related to the amount of UV light that you get. Those things will actually prevent cancer. Again, 42% of all cases of cancer in the United States in adults 30 and over were caused by modifiable risk factors. 45% of cancer deaths are caused by cancers that could have been prevented. Much more effective to prevent a cancer than to screen for cancer. Again, these are the risk factors just listed in a different fashion. Cigarette smoking, radon. So radon is probably the second leading cause of lung cancer. Radon is a gas that occurs naturally here in Iowa. We're a hotbed of radon. You should check your home for radon. If you have a high radon level, you should mitigate by venting the radon out of your house. That will help prevent cancers. And then again, we talked about alcohol intake, body weight, physical activity. In terms of nutrition, it's the sheer number of calories, but it's also what we eat. So eating red meats and highly processed meats results in more cancer. Eating a low amount of fiber results in a higher incidence of cancer, and having a low fruit and vegetable consumption results in a higher risk of cancer. And then the last is infections. So we know that infections cause approximately 10% of cancers, and the infections that lead to cancers are HPV, HIV, hepatitis, and herpes and Heliobacter. And these are all infectious diseases for which there are either vaccines or treatments that can thereby help prevent them from going on to cause cancer. So we're going to get rid of the slides. I think we're done with the slides, and we're coming back to real life here. Let me just summarize that there are many ways of reducing the burden of cancer in the United States, of reducing the number of individuals who will die of cancer. The number one best way is to prevent cancer. The second best way is to screen for cancers that we have valid screening so that they can be found at an early stage when they are curable. And that's what this talk has been about. So we're going to open it up to questions and answers now. So if you are watching live streaming, please type in any questions. And if you're here with me in my live studio audience, we'll take questions right now. Tim has a question. Sure. We can always trust Tim, to rely on him for a good question.
I didn't know I had a question, but I knew I have a question now. So you talked about breast cancer, and then there's the breast cancer that's maybe I can say normal, which is, you can see it really easily. But can you talk a little bit about screening of those breast cancers that have high density fiber?
Yeah, that's a great question. And so we're talking about women who have dense breasts. So when a woman has a mammogram, we're looking for an abnormality, a subtle abnormality that might be early stage breast cancer. And the mammogram is, as we talked about, the valid tool for screening normal risk women. So when you get a mammogram, not only do you look to see is there any evidence of cancer, but the mammogram doctor will score the breast based on density. And we have 4 different scores, A, B, C, and D. A is assigned if the doctor looking at the breast says, there's not much density here. There's a higher ratio of fat to breast density. We'll grade it an A. A little bit more dense is a B. A little bit more dense is a C. Very dense breasts are D. We call a C and D category as dense, and A and B is not dense. It's absolutely, totally true that you can find a breast cancer easier on a mammogram in a woman that has grade A or B dense breasts. And that if you have a woman with D density, the whole breast looks very white. So seeing a small white dot in a breast that's all white is very, very difficult. Whereas in a breast that isn't dense, most of the breast looks black and you're looking for a white spot in a black background. Much easier to see than looking for a white dot in a white background. So the question, and it is a bit controversial, is whether women who go in to get a screening mammogram who have category D breasts should go on to have additional imaging. I already told you that the science doesn't support doing MRIs on every woman as part of screening, but there are proponents that for women with stage D density breasts, that using MRI periodically, probably not once a year, but periodically may yield more early stage breast cancers that could save lives. So that is an important area that is still being researched. And we do use those advanced images that I talked about, ultrasound, 3D mammograms, and MRI as advanced images for women who have an abnormality on the mammogram, or perhaps for those women with very dense breasts. So thank you for the question. It's really important. We believe that every woman should know what their breast density is, because another thing that the women should know is if you have an abnormality in your breast and your doctor does a mammogram, they say, well, your mammogram's fine. That's not the end of the story. If you feel something, but it doesn't show up on mammogram, that doesn't mean that it's not cancer. You may still need to undergo more advanced screening. Because if you feel something in your breast, getting a mammogram is not a screening mammogram. It's a diagnostic mammogram. You have a symptom. So if you have a symptom, pain, a nodule you can feel, or discharge from your nipple, and you do a mammogram and the mammogram says we don't see anything, that's not the end of the story. You still have to have more advanced imaging to try to determine what's the cause of the symptom. Other questions from our live studio audience?
Doc.
Yes, sir.
I love you like a brother, first of all. Okay, so the question I have is, you made the statement that you haven't gotten PSA tested for, I don't know when, but I'm just wondering, is it something that, I'm just asking the question, why is it that you yourself have not checked your PSA, or maybe you do and I'm not following the whole situation?
No, I haven't had my PSA checked, and it's because the science does not show that it's testing average risk men such as myself results in a lower death rate to prostate cancer. It definitely increases the chance that someone would find some cancer and that would lead to treatment that might have side effects and may not provide benefit. So philosophically, I know I'm going to die someday of something. And I personally accept the risk that by not screening for prostate cancer, I may someday be found to have stage 4 prostate cancer and not have had the opportunity to have cured it. But my understanding of the science is that the chances that I would die of prostate cancer because I didn't do screening is so low, and the chances that I would have to have biopsies and treatments if I did the screening high enough that I have concluded, based on my knowledge of the science, that I am willing to accept the risk of not screening. So it's an informed risk based on science, but intelligent individuals, patients, and doctors may come to a different conclusion. And that's why both the American Cancer Society and the Task Force on Screening both agree it's grade C. You can do it. It's not proven to be absolutely conclusively beneficial, and it does have some risks associated with it. So intelligent people can come down on either side of the answer should you have PSA testing done as part of a screening.
Well, my question again back to you is that, what if I would have been in that same situation thinking about myself? Now, I don't have the knowledge that you have in regards to the different types of cancers. But if I would have had that same feeling that, I'm healthy, I'm active, I'm maybe a little overweight at one point in time when I was, younger. I did drink a little bit more than I should have when I was younger.
This isn't true confessions. You don't have to tell me.
Okay.
I'm not a priest.
But I just wonder, in that situation, what if I took that same type of attitude?
What would have happened to my friend SR if he had never had screening? And we don't know the answer. I mean, and I love you, man. And the one would like to conclude, that, oh my God, I would have died of prostate cancer had I not been screened. Another possibility would be that you would have lived with cancer in your body and never known it. And that you would have lived a normal life expectancy, died a normal death of, I don't know, getting kicked in the head by a horse, and that you never would have known you had cancer. We don't know which of those conclusions is true. And I think it's too much to ask any man who's been treated for prostate cancer to imagine that maybe they would have been fine had it never been found and they never received treatment. That's a difficult pill to ask anyone to swallow after they've been through lots and lots and lots. And no one knows which category you would fall in. But there are men who absolutely, I don't know if it's the majority or the minority, but there are men who would have been fine had it not been found. And the reason it's category C, we don't know, is the data doesn't tell us for sure which camp you would be in if you weren't screened. So I would like to believe, my friend, that you did the right thing and that the path you took has led you to a healthier state than had you not been screened. But excellent question. Other questions?
So I'm approaching the age of 45 for the colorectal screen. And you said that had recently changed from 50 now down to 45.
Yes.
Are most insurance companies covering those screenings?
Yes.
And do they cover just the at home, or are they covering the full colonoscopy?
Almost all of them cover at age 45, and almost all of them cover either the stool test or the colonoscopy. So both the American Cancer Society and the United States Preventive Services Task Force give it a very favorable rating, and the insurance companies has quickly picked up on it. And I would be very surprised if your insurance company doesn't fully cover it and allow you to have a colonoscopy. As we mentioned, one of the advantages of colonoscopy is it actually can prevent colorectal cancer by removing polyps. The disadvantage is you have to take a day off work and have the procedure. I think most people who have good insurance and the flexibility of taking a day off, tend to favor going the colonoscopy route, but they're both considered equally effective in screening for cancer. Other questions? Oh, I see we're out of time. Sorry about that. So let's bring it to a conclusion. So thank you for attending tonight. We talked about how to reduce the death rate by preventing cancer and screening for cancer. I'm Dick Deming, Medical Director, MercyOne Cancer Center. If you think someone would benefit by watching this, you can direct them to the Above and Beyond Cancer YouTube channel, where this presentation will be available for on-demand viewing at any time, or the MercyOne Cancer Center website. Thanks again for attending, and please come join us again next week. Bye, everybody.